Hello everyone, my name is Tiara and we are here at School-Based Health Alliance. We'd like to thank you all for attending today's exciting webinar titled How One School-Based Health Center Network Transformed a Community by Addressing Asthma. We have a few housekeeping reminders just before we get started. If you are viewing as a group, please go to the chat window and type in the name of the person registered and the total number of attendees, people in the room. For example, Tierra Brooks +3. This will help us with our final attendees account. All right, just a few reminders. You are all in listen-only mode. However, if you want to hear questions, please enter them in the chat box. To ask a question at any point during the webinar, please use the chat box that's located in the GoToWebinar control window. We will address questions following the presentation. Attendees will be asked to complete evaluation questions at the end of this webinar. This will be great feedback because it's vital to helping us craft presentations that will meet your needs. Also, webinars will be archived at School-Based Health Alliance. You can log on to www.sbhforall.org/webinars. Right before we get started, we actually have a few poll questions for you. The first poll question is, are you familiar with the EPR3 asthma guidelines? Let's just take a few seconds to answer this question. Five more seconds. All right, it shows 42% is not familiar with the EPR3 asthma guidelines. Well, let's find out another question. Are you currently using any validated tools for your patients? Just take a few seconds to ask this question, yes or no. Five more seconds. Okay, wow, 77% of you are currently using any validated tools for your patients. Great. All right, one more question. Are you working with your community partners to improve health outcomes and population health? Yes or no? Let's take a few seconds to answer this question. Five more seconds. Okay, great. 80% of you said yes. Thank you all for answering these poll questions right before our presentation. Now I will present our presenters. Today's presenters are first Deborah Gerson, and then we have Elette Hirschhorn. Please help us welcome Ms. Deborah and Ms. Elette.
Okay, hi everybody. My name is Deb Gerson. I'm a family physician. I'm the medical director of the school-based health centers with Open Door Family Medical Center, and I'm also one of the site medical directors at Ossining Open Door in Ossining, New York.
And I'm Alette Hirschhorn, the Director of Clinical Programs and also the Director of the School-Based Health Programs.
Neither Alette or myself have any financial conflicts of interest to disclose.
Okay, today's objectives, we're going to go through how to understand the school-based health center, how a school-based health center network transforms a community by addressing asthma.
We'll be identifying tools for asthma measurement to improve clinical outcomes and identifying strategies that other school-based health centers and community health clinics can replicate.
Okay, I'd like to acknowledge our community partners. In particular, I'd like to acknowledge Jacqueline Rubino, who's the director of the Hudson Valley Asthma Coalition through the American Lung Association. She really helped to generate and to really move our program. We work closely with the Westchester Children's Environmental Center, the Visiting Nurse Services of Westchester County, the Portchester School District, our health plans, the pharmacies in Portchester, the daycare centers in Portchester, also tobacco-free schools and Power Against Tobacco through the American Lung Association. All right, a little bit about Open Door Family Medical Centers. We have 5 federally qualified health centers in Westchester and Putnam counties. We have 6 school-based health centers. The ones in Portchester are community schools as well. We have 2 dental trucks, one specifically for our school-based health program. Last year, we serviced almost 43,000 unique patients with almost 217,000 visits. Close to 5,500 children are over 5 years old. Within our program, we have a pediatric residency program, a family practice residency program. We have a dental residency program. We're an accountable care organization and a health home. We're medical home certified level 3, and we also have a wellness center for our patients and our staff.
Here's a community snapshot of the Portchester community where we were working when we initiated this project. There's 1 community health center, 5 school-based health centers, 3 daycare centers. In this community, 30% of the families are between 150 to 200% below poverty level. The free and reduced lunch rate is 69%. That's in contrast to the county-wide rate, 28%, and the statewide rate is only 39%. Portchester has the lowest per capita income of the 44 communities in Westchester County. The mean per capita income, $21,000 for this community. 31,960 residents, almost 7,000 are children, 6% are under 5 years of age, 15% are 5 to 17 years of age. 72% of our population is Hispanic, and the school district estimates that more than 75% of the Hispanic children in the district are children of recent immigrants.
In terms of health indicators, 18% of the children in the Portchester School District have an asthma diagnosis. 36% of infants have had either delay or no prenatal care. 6% of the children were born underweight, and 45% of the children are either obese or overweight.
So when we first began collecting data for this project in 2007, this was the starting data. There were 376 missed school days due to asthma. The asthma severity was qualified in 15% of the students. The 23% of the students with persistent asthma were on an ICS. Only 15% of the students had an asthma action plan. 50% of the students were documented as well controlled. There were 470 acute care visits to the school-based health center, and the emergency department visit rate was 24.7 per 10,000. I just want to put in the percentages here. The way that the information was collected was something that we're working on with this project, because early on, without using the validated tools, a lot of the the data was based more on a subjective provider diagnosis without using a tool to really be able to really classify that student.
So these were our plan and our measurements. Again, this was developed in conjunction with the Hudson Valley Asthma Coalition, the Portchester School District, and the Open Door. To the school-based health center by 50% among elementary, middle school, and high school students. We wanted to reduce the missed school days by 50%. 80% of the students, we wanted them to have a documented level of asthma severity. We wanted 90% of the students who had a diagnosis of persistent asthma. They should be on an ICS. We wanted 100% of the students to have an asthma action plan, and we wanted to make sure we exchanged that with the families and the school nurses. And we wanted to increase the number of updated asthma action plans by 70%, 75% of the school nurse's office.
So the tools that we used to improve the care for the EPR3, that was the updated guideline for diagnosis and management of asthma. The Asthma Friendly Schools Initiative from the American Lung Association, and using the chronic care model, or the care model for child health. The EPR guidelines include the 4 components of care, which are assessment and monitoring of severity and control, control of comorbid conditions and environmental factors, education and for partnership and care, and prescribing the correct medications and monitoring that as well.
And people could download the guidelines from the internet if you're not familiar with them.
Right, the EPR3 guidelines are free on the internet, and you can download a summary report of the EP3 guidelines. The 6 priority messages that we brought to the students and the community were asthma severity, being able to correctly diagnose the severity, asthma controlled, the use of inhaled corticosteroids, the use of an asthma action plan and education, allergen and irritant exposure control, so monitoring the triggers, and follow-up visits. This is all in the chronic care model, but this is all part of the EPR3, which we've embedded into the care for all these students.
So this is this next slide depicts the chronic care model. So we called it the chronic care model for child health. And again, it mimics the EPA guidelines. So working with the community resources, changing policies within your community, within the school district, focusing on our particular healthcare organization, ensuring that the student and the family have self-management support, the delivery design system. You'll see we embedded a lot of our prompts in our EHR, including decision support, and again, all of this together really helps to build a healthy community.
Okay, so the delivery system design, that's everything from working with the providers, working with the district, and working with your electronic record. So in this, we identified an asthma champion. That's very important to find somebody, and it does not have to be a provider. Our asthma champion was actually someone in the district who was not a provider. But that's very integral. You need to make sure that you have the right people who are supporting you, and the people who are supporting you that other people will listen to. So it might not always be an insider coming in from a healthcare organization to tell parents and families and teachers and school nurses what they need to do. It might be someone else.
In our particular case, we identified the Director of Health and Athletics, who is now the Superintendent in Portchester School District. So he both had the responsibility to work with not only the school nurses, but all the environmental services, the bus drivers. So he really helped move our project along. Without Joe Journey, I really don't think this was possible. We talked about this at all our district wellness committee meetings. We meet on a quarterly basis, and both him and I would give a report to 20 committee members.
One of the next things we did was to try to identify the students with asthma. As I said early on, we weren't really using validated tools, and a lot of the students who very often were patients of the federally qualified health center as well were not identified as having asthma, though looking through the charts we could see they'd been in for multiple visits for cough or for shortness of breath, but they weren't identified as having a diagnosis of asthma. So part of the message was trying to get the providers and the nurse practitioners to start looking at those students and use a validated tool to assess them, to see if they have asthma, get a good family history, look at things that trigger them. So making sure we're starting out with the correct data. Again, collecting baseline data on the student attendance records. So that was working closely with the nurse in the school to try to come up with a way when a student is out to have the nurse call and find out what they were out for, whether they were out for cough because they were short of breath, finding out what they were missing class for. Collecting the number of visits, the data on the acute care visits, both to the federally qualified health center, to the school-based health center, and again, emergency room visits. And embedding the guidelines in the EMR, that was very important because the EPR3 it's a lot of pages. It's hundreds of pages. Even the summary report is about 75 pages. Providers are busy. They don't have a lot of time to read that and try to figure out a way to incorporate it into their practice. So using our electronic record with triggers and reminders for them, it made a huge difference for them, everyone to be giving the same message no matter who the patient saw. And using the planned care visits at least 2 times a year. In our school-based health center, we call the patients in 3 times a year. Those are the patients that are well controlled. And then more is needed to assess their asthma as the seasons change. Here's an example of the asthma template that we had embedded into our electronic record. So you can embed anything in there and it can be collectible as well. So again, with the EPR guidelines, assessment of asthma severity is there. If you click that box underlying asthma, it'll open up to a form, to the severity assessment form, where it'll ask you how many times a week they're using their inhaler, different questions that bring you to the answer of what type of asthma, how to categorize their asthma. Asthma control as well, that'll open up to some questions that you can find in one of the validated tools. The number of acute or ER visits in the past 6 months, that's important to know. Generally that's important, but that's also one of the ways that you're going to diagnose, figure out the asthma severity for the patient. And the asthma action plan, so you can have the date of their update in there because that needs to be done yearly.
With this, as Deb said, we were able to collect the data, so we would be combing over the data every month to see what kind of improvements we needed to make. We did a lot of PDSA cycles, where we would try something rapidly in one of our school-based health centers. We would see in a day or two if it worked. If it didn't work, we would make some rapid changes. So I think that really is the key to the improvement model, is to really see what's working and what's not working, and really changing it quickly before you embed it in for good into your systems.
This is an example of, we have flow sheets in our electronic medical record as well. So many of the things that the providers were adding in, the peak flow, if they were doing peak flows, the asthma severity will be automatically pulled into this flow sheet. So when the patient came in, they're able to open up the flow sheet and see the date of the last assessment and whether something's due or not for them, the last trigger assessment or the last time an asthma action plan was done for them.
We wanted to, of course, make sure that all our asthmatics get their yearly flu shot as well. Okay, we're back to the care model and decision support.
So again, this was it was a long process, but we did a lot of clinical training for the providers. We went from site to site to train the providers on the guidelines, on using the validated tools, and it wasn't always easy. It was rocky sometimes trying to get everyone on the same page because everybody's so busy. But I think as time went on and people were much more comfortable with using the tools and everyone began speaking the same language visit to visit, they realized it made it so much better for them because there were much less acute care visits for the asthmatics coming in the winter time. So teaching the providers how to use the validated tools, embedding them into the EHR.
And our nursing staff as well.
Nurses, yep, and assessing asthma severity yearly. Asthma control assessed every visit. So that's one thing. We made it like a vital sign in a way. So instead of just when the patient came in for their asthma visit, if the patient was coming in for anything, for suture removal, they would have their asthma assessed because you want to catch them early and make sure that they're in good control every single visit. So it did become part of the same as doing a vital signs. And the school nurse and the school-based health center nurse both assessing who's using the pre-exercise medications and making sure that they're taught appropriately about using the medications, and those students that are able above the 4th grade level, teaching them and teaching their parents that they're able to self-carry the medication and administer it as needed.
When we first started to look at the extent of this project, we realized that there were so many kids sitting out during physical education or not participating in sports that we, and we do this on a yearly basis now, we deliver Asthma 101 and Asthma 102 education to everybody within the schools, including the coaches, including the lunchroom ladies, including the janitor staff. We felt it was important that everybody in the school really knew how to handle asthma and also knew who their asthmatics were.
This is one of the validated tools that we use. It's called the ACT, the Asthma Control Test. People are probably familiar with this one. There's one for 4 to 11 and one for 12 to adult. So this is a tool that we have laminated now in each room of the office at the clinic and also in the school-based health centers. So every time a patient with asthma comes in, the nurse or medical assistant can see in their diagnosis that they have asthma. They'll give this to, if they're old enough to read, they'll give it to the child or they'll give it to the parent. And by the time the provider gets in the room, no matter what they're there for, the provider is going to know if that person is in good control or not in good control. So this is a validated tool to assess their control rather than previous to starting this project, the providers were assessing control more based on saying, how do you feel? Do you feel like your asthma is in good control? If the student said yes, then they would check that they were in good control. But we know that there's some people that are poor perceivers and some people that are extra sensitive perceivers of their asthma. So we really needed a validated tool to know when we needed to intervene or just reinforce. So every student gets this every time they come into the health center.
And in actuality, the students really know these questions, so they'll know in advance if they start to feel ill, they'll come into the school-based health center as well.
This is an order set. So embedded in our medical record, we can also have certain order sets based on diagnosis. It's another way. Some providers use them, some don't, but it's another way to quickly pick and choose from the list of what you want to prescribe, but also a reminder of what should be prescribed. At the top of the order set, you can't see it in here, but there's a box where you can write down when they should be assessed and little different reminders for yourself. For the follow-up appointments too, this was important because a lot of the providers were seeing patients with asthma, treating them, and then saying, come back PRN. So we really reinforced by having this in the order set that the follow-up for an asthma exacerbation needs to be soon, and if someone's controlled, usually within 3 months, although if they're very well controlled, it can be prolonged to 6 months for older that really can control their asthma well. At the bottom also, we were able to add in some patient education. So the asthma control test is down there. The provider can just click on the box and print it out for the patient and the family, and some other information about asthma as well that can be given to the family. The asthma control test is also a great teaching tool. So all of those validated tools are really something that you'll be using to help yourself, but they also really, our goal is to help the patients and the families to have control and to know when to come in. So those tools also help the families to learn what is and what isn't good control of their asthma. This is what we call our report card at Open Door. So each quarter, each provider and each site will get this report card, and they're able to see, this is a site report card, but each individual provider also will get one of these. So they'll know how many of their asthmatics who are persistent or on an inhaled corticosteroid, and many times it's a more question of whether they've documented it correctly, because it has to be ordered in order to be collected. But in a way that we use our report card as a teaching tool as well, so you can see what the goal is and you can see if you're going up or down. We also have something called Tableau, which is another way the providers are able to look at their progress with the different diagnoses, and asthma is one of them, and assess how well they're doing. And they're able to click on Tableau, which I don't have an example of here, but they're able to actually print out an Excel sheet with the names of their patients who are do not have an inhaled corticosteroid, so they can call them in to make sure they get either correctly diagnosed or correctly treated.
And I think this also goes hand in hand with a patient-centered medical home, where our providers really do have the opportunity to know in a snapshot by looking at Tableau who their sickest patients are. In this case, of course, we're talking about asthma, but in general, you know, who of their diabetics are not in control, who of their diabetics did not have an LDL in the past year. So we're able to, the whole team is able to look at their actual patient load to know who the sickest patients are and to know to call them back. And again, as Deb said, this report card is presented from the top of our organization. It's presented to our board of directors. Every quarter, our CMO, Dr. Darren Wu, presents this to the board and to all the senior management. So everybody, including our CEO, Lindsay Farrell, she is very, very, very involved in all the care aspects of what's going on at the Open Door. Okay, so here we're back to the care model.
So clinical information systems, we developed an asthma registry, and the staff in the school-based health centers uses this to know who their asthmatics are, how often they've been in. Each asthmatic will have yearly spirometry. Usually starting at kindergarten, we're doing spirometry on every asthmatic in the school-based health center. And again, it should be done in the centers, the health center as well, but it's a little bit more difficult there to get them to do that yearly. But in the school-based health center, that's something that each asthmatic has. And the way that the protocol, the algorithm works, students who present to a school-based health center with any respiratory-related symptoms are assessed by the nurse, and the control levels and medication management are reassessed at each visit. The school nurse was really a big partner for us as well, because she would often say to the nurse practitioner, this kid's been in for a lot of coughs and I think they need to be assessed for asthma. So that was a very important relationship there. And the patients will get reminder phone calls prior to each planned care visit. And for each patient that doesn't show up, they're tracked and they'll be called, and we make sure they come in for their quarterly visits for asthma.
Of course, in any school-based health center, the no-show rate should be very, very little, because the students really, we could call them down whenever we need to. Okay, community resources and our policies. You saw at one of the slides at the very beginning all the partners that we worked with, and they're, we include them in our community, and that's really how we build healthy communities with asthma and really with any population health indicator. But here again, we partnered with our friends at the American Lung Association. We again, we assess smoking on every student at least yearly, if not more often. Our smoking rate was high at the time among our high school students, so we were able to administer the Not on Tobacco program, which is a validated program by the American Lung Association. And on a very timely, we just looked at our student data yesterday in terms of smoking, and it dropped by almost 10 percentage points. So we were very, very happy about that. We worked with the Village of Portchester, who helped us implement tobacco-free parks. So in any recreation or park in Portchester, there's no smoking. We worked with the bus companies and, again, the town to institute no idling policies. We gave, and we continue to give, once a year to all the bus drivers. Portchester has some buses, so we continue to give them in-service on idling, on Asthma 101. We really dug deep in our schools and taught our parents about not idling. We initiated the Asthma Friendly Schools initiative, which I'll go through in just a few minutes. We work with our daycare programs, our pharmacies, to make sure that they were administering exactly, if the provider were writing for 2 ICFs, one for the school and one for home, they were given it. We work with our healthcare plans to make sure that they paid for both. We instituted a program with Visiting Nurse Services of Westchester for any uncontrolled asthmatic. They would go in and still can go in and continue to do a home visit to look at any triggers, environmental triggers that might be evident in the household, and again working with the American Lung Association. So some of the steps to create an asthma-friendly school: we identified the students with asthma. We continue to do that really every day. We allowed our students to carry their rescue medications. We instituted policies. We instituted a school-wide protocol for handling asthma, and you'll see that in the next slide, where we actually hung protocols in every single classroom. Again, we taught the teachers and the lunchroom ladies. We wanted everybody to feel comfortable and how to handle an asthma episode if somebody was having an acute asthma episode. We identified and reduced common triggers in the classroom. Again, with our asthma champion, Joe Journey, him and the superintendent, the assistant superintendent for environmental services, went all green, all natural. So all the cleaning products in Portchester are all green and all natural. We continue to collaborate with the families, healthcare, and providers at the schools. For those of you who are not aware, but I'm sure most of you are aware, that there's a New York State law which allows students to carry their self-medication. Normally, the provider will have to write an order, and the parent will have to bring in the medication, and either the school nurse, but in our case, our students are carrying it.
We did a lot of education with the nurses about that, and also the teachers. People were afraid to have the students carrying their medication. So really educating everyone in the school that it's safe and it's the best thing for any student who can carry their medication. We also educated the nurses about checking, and the families checking the expiration date when school starts again, or if there's been a vacation, making sure to prime the inhalers, how to make sure the inhalers are clean. So all of the type of things that would affect the students not getting the best use of their medication.
I mean, when we started this program, we realized that kids really did not know how to administer the inhaler. They were just really putting it in their mouth without really taking a deep breath. So this is an example of a school-wide protocol. If you wanted this, you could download this on the American Lung Association site. The protocol for responding to an asthma episode, and this is actually built in to the school-wide district policies as well, their policies and procedures. Again, so everybody knows who to call, who the designated staff members to call, really what to do if 911 might need to be called, and to always, of course, notify the school-based health center, the primary care provider, the parent, and the guardian. This is a book that Open Door created. This is just a cover. If anybody was interested, you could email me or Dr. Gerson. At the end, we have our contact information. But this is an educational booklet that we designed to go home with every family or every child who has asthma and helps them identify the triggers that might be in their homes, and how to clean their homes with green products, and to how to identify an asthma attack as well.
So here's the metrics versus 2014 from the metrics we first started off the slideshow with. So you can see the difference as well, but the missed school days dropped from 376 to 28. The asthma severity was assessed in 100% of the students. It was embedded in our record. There was actually no way they could avoid having to do the asthma severity assessment, and it was collected on our report card and fed back to the provider and also to the medical director at the sites. The percent of students with persistent asthma who were on an ICS and who was correctly prescribed went from 23% up to 98%. 100% of the students had an asthma action plan, and the school nurse was actually very helpful with that as well and would remind us when they needed the asthma action plan. 100% of those students were well controlled by the use of a documented assessment tool. So again, it wasn't subjective, it was the use of a validated tool, sorry. And the number of acute care visits to the school-based health center dropped from 470 to 23. At one of the sites, they were actually able to get rid of their nebulizer machine. They had used it so little in the last year that they no longer needed it. The emergency department visit rate went from the 25 per 10,000 to a number that was so low it was too low to count.
And again, this outcome data is the Sparks data, which is directly out of Westchester County.
So we knew that the educating the parents and reducing risk was the most important thing that we could do to try to intervene early before there were any changes. That's part of the EPR also. So we used the same approach to start working with the daycare centers in Port Chester. There were Head Start programs for children from 3 to 5, and using the same model, we started working with those daycare centers using this chronic care model.
And again, working with the, Jackie Rubino and her team from the American Lung Association. So these were some of our initiatives. We wanted the nurse at the Head Start to screen every student who was newly registered and every year using the brief respiratory questionnaire. Again, because we don't have a school-based health center in these Head Starts, we wanted anybody who was positive to be referred to the Open Door Family Medical Centers in Port Chester. We did a lot of education with parents and staff. We continue to do that. Our patient advocates still do that a couple times a year. We wanted to decrease the acute care visits, decrease missed school days, and decrease hospitalization.
So this is, I won't read everyone, but this is a brief respiratory questionnaire. It's another validated tool, and this is for specifically for younger babies and younger children. So the questions basically just get at has the child had multiple cough visits? Have they ever been diagnosed with some of those other terms that people will use instead of asthma, wheezy bronchitis or reactive airway disease or chronic cough, to try to really see if this is a child that might have asthma. Have they ever been given a nebulizer in the emergency room? And you'd be amazed how many parents answered yes to that question. So they had been treated with albuterol and had a good result for it, but weren't really given the tools or the education to know what to do to prevent their child from having a recurrence of this coughing diagnosis. So anyone that had a yes answer, when they entered the daycare center, when they registered, the nurse at the daycare would give this questionnaire to every single parent. It was irregardless of any history that they gave. And if they answered yes to any of the questions, they were sent over to be seen by a provider who could do a further assessment. So here's the outcomes from the Head Start. It's 2010 when the project was started there to 2014. So the graph speaks for itself. The number of patients was 48 for each one. And since the project, the number of acute care visits to the health center went from 257 down to 8. Hospitalizations to 0.
And I think on the previous slide you were able to see that they really can't even count. It's too low to count the ED and the hospitalization rates with people who live in the Port Chester zip code.
So here's some links. You know, the EPR 3 guideline was really what this was all about, and we have to again thank Jackie Rubino, because with her guidance, this project really followed the guidelines, but made it much easier for the providers to be able to do it, for the parents to be able to follow the guidelines and prevent long-term poor outcomes for their children. So the EPR guidelines really stress to reduce impairment and reduce risk, and that's what all of this has been about. And hopefully, you know, children will continue to have less school days, less missed school days, and will help them to be much more successful.
Just something that I neglected to mention earlier, talking about the asthma-friendly schools. Since 2007, our health educators have been delivering the Open Airways curriculum to all students of grades 3 to 5 in elementary, kicking asthma in the middle school as well. So these kids really get an intense 6-week workshop with one of our health educators to really learn about their triggers, asthma action plans, what to do if they start to feel bad. And I think with all of this, we really started to see the kids advocating for themselves and coming to the school-based health centers when they are not feeling well, and their parents calling our nurse practitioners in the school-based health centers when they detect that their kids might not be sleeping through the night, or their child might be coughing and waking up. So our education efforts paid off big. Again, these are the final slide is our contacts. So my contact, Deb Gerson's contact, and Jacqueline Rubino's contact from the American Lung Association. I'm sure she'd be very happy to talk to anybody who might be listening in on this call, as we would. And I think we're going to turn this over to Tiara right now.
Yes, thank you so much, Deborah and Alette. I enjoyed learning about the care model and tools used to assess someone with asthma and the many ways you all connect with your community. Thank you so much for this information.
Our pleasure.
Right before we get to the questions, I just want to let everyone know that please enter your questions in the chat box if you have any questions for Deborah and Alette. We're just going to give you a couple of minutes to enter your questions. So right before that, I just want to mention we would like for you guys to please become a member of School-Based Health Alliance. At School-Based Health Alliance, we work to improve the health status of children and youth by advancing and advocating for school-based health care. So we just want to extend this membership, and please join us. We have two types of membership, individual or organizational. Organizational memberships are $500 a year, including discounts on professional services and products, letters of support for grants, newsletters, and more. And individual memberships are $100 a year. If you have any more questions, please go onto our website at sbhforall.org under membership, and we'll be more than willing to help answer any more questions that you may have. All right, we do want to open the opportunity for anyone that has any questions for Deborah and Elette. We really appreciate them for coming, for just speaking today. Everything was so informative. All right, we just give everybody one more minute. All right, Deborah and Alette, it looks like everything you mentioned was very informative and helpful for anyone. Is there anything else you would like to add before we ask just our attendees a few questions?
No, I think that's all we had. I mean, we worked very closely with getting our entire community to buy in. We have many networks in our community, a lot of meetings. So our staff, our parents would always would be talking about our efforts to really improve this. So again, there was a lot of community involvement.
All right, well, thank you so much. And we do have just a few questions for our attendees. Our first question, we would just like to ask you guys, does this presentation meet your needs? Please just let us know, yes or no. And we'll just give everyone a few seconds. Five more seconds. All right, the next question. How well did the presentation meet the stated objectives? Please choose from A, B, C, or D. Thank you very much. Five more seconds. All right, how likely are you to apply information from the presentation in your organization? And we'll just give everyone a few seconds to answer. Five more seconds. All right, and would you recommend this webinar to others? Yes or no? We give everyone a few seconds. Five more seconds. Okay, everyone, we would just like to thank everyone, including our presenters again, Deborah and Alette, for this phenomenal presentation. And just a reminder, our webinar will be archived in 3 to 5 business days. So if you are interested in viewing this webinar again or sharing with anyone you know, please go to sbhforall.org. Thank you and have a great day.